Greetings from MGMI Institute and India. At the outset, I would like to thank CyberSight for giving me this opportunity to present our experiences in treating microbial keratitis with you all. And I would like to thank the CyberSight team for facilitating the technical aspect and making this webinar a go. So microbial keratitis is very important because most of us face these kind of patients every day in our clinics, and sometimes it can be very challenging. So the webinar plan is basically to showcase 5 cases. I've curated these 5 cases, and each of these 5 cases show some challenging aspect that we sometimes encounter while treating corneal ulcers or microbial keratitis. And I intend to share with you all how we went through the ups and downs in treating these kind of patients. Before we go into the particular cases, I would like to just give a brief overview of management of microbial keratitis. And that is, first of all, we need to differentiate whether it's an infectious infiltrate or ulcer that we are seeing or a non-infectious. And if it's infectious, then we need to identify the organism. This we do with the help of detailed history taking, looking at the ulcer characteristics through this with the slit lamp, and then doing a microbiology workup. At the same time, we also need to address the various risk factors. Common risk factors are lid abnormalities, ocular surface disease, chronic dacryocystitis or nasolacrimal duct obstruction, and systemic disorders like uncontrolled diabetes. Once we have the organism, we know the organism, then we need to kill the microorganism with the suitable and appropriate antimicrobial agent in appropriate dose. And as we treat the patient, we also need to take care that we maintain the ocular integrity of the eye, prevent the eye from perforating, the cornea from perforating, and do any measures like a glue BCL, the cyanoacrylate adhesive, bandage contact lens, or a therapeutic penetrating graft to maintain the structure of the cornea and the eye. So without much further, let us go into the first patient. And this first patient will teach us how we need to use topical corticosteroids in bacterial keratitis. For many, many decades, this was a very controversial issue, and I thought I would start off with this. So this was a 50-year-old mechanic who came to us with a 7-day duration of pain, redness, and watering. He gave a history of trauma while he was welding a piece of metal. There were no known risk factors, and he used some eye drops over the counter. If you look at the slit lamp photographs, you can see that there is a central corneal ulcer, the color of which is yellowish. It has a leading edge. We call that the leading edge because the infiltrate is very dense there. And there is a area, if you see on top, let me use. Yeah. And if you see superiorly, then you can see that there is a healing edge. The infiltrate density is less there. And it is full thickness, and the surface appears to be wettish. The margins are well defined, and there is an hypopyon. So this is typically what we call a serpiginous ulcer. Some old books would have this serpiginous ulcer title. And normally this is caused by Streptococcus pneumoniae. And we suspected that clinically because of its very characteristic clinical signs. And when he did a corneal scraping, we found that the gram stain showed cocci in pairs and chains. And even before the culture and given the clinical thing, we suspected this to be a gram-positive bacterial infection, Streptococcus. We still needed to await the culture reports. So given that the ulcer was central, there was hypopyon, the vision was less, we started the patient on fortified antibiotic, cefazolin 5% eye drop, intensive dosing, 1 drop half hourly, and supportive treatment in the form of atropine sulfate and oral non-steroidal anti-inflammatory drugs. The culture came back with a positive history of Streptococcus pneumoniae, and we found that the antibiotic susceptibility report that we got showed that the bacteria was susceptible to cefazolin. So now I would like to take a quiz and poll your opinion. What would you like to do now? So I think Lawrence can share the quiz. Okay, so what we get is that the first choice that has got polled the highest is we continue with the same antibiotic. 47% of the viewers have said that. 17% wanted to change the antibiotic. 23% wanted to add a second antibiotic, and 14% wanted to add a topical steroid. So let's see what did we do. So we chose topical steroids. And why did we choose that? One, the ulcer had responded, the hypopyon had subsided, there was some reduction in the infiltrate density. The antibiotic that we were using, cefazolin, the bacteria was susceptible to it. So it was not rational to start to either change that antibiotic to a second antibiotic or add a second antibiotic, because a second antibiotic would increase the incidence and risk of drug toxicity. We didn't want that. Instead, we wanted to now reduce the inflammation significantly, and that we did by adding topical steroids. I had mentioned that this was very controversial few years or decades ago, but recently this landmark clinical trial, the steroids in corneal ulcer trial, or the SCUT study, the findings of that study has given us enough confidence to start topical steroids at this stage. So what does the SCUT study tell us? It tells us what steroids cannot do. It tells us that steroids cannot lead to a better vision, cannot reduce the scar size, and also it does not cause more corneal perforations, which was one of the concerns for using topical steroids in corneal ulcers. And what the SCUT study also tells us is that it is not recommended if the organism that you get is nocardia. So it is contraindicated in nocardia. Then why should you use steroids? What are its benefits? This subgroup analysis of the SCUT study shows that steroids are particularly beneficial in patients who has a poor presenting visual acuity, counting fingers or worse, which our patient had. In central ulcers, our patient had that. Ulcers that are deep or of full thickness, and larger ulcers. In brief, steroids are beneficial in ulcers which are large and which can cause more harm or reduce the visual acuity more. And that was what this study told us. And if you see, we need to know how to use it also. So there are some check boxes. And the first checkbox is that it should be a bacteria, and the bacteria should have been identified through culture. In our patient, we tick this box that the bacteria is susceptible to the antibiotic that we have been using, or have been using. It ticks that box. That the antibiotic has been used for at least 48 to 72 hours in adequate dose. This also ticks that box. And a clinical response has been obtained. We got that clinical response. So once you are able to tick all these check boxes, you can start topical steroids, which we did. We used prednisolone acetate. And if you can see the results, you can see the result that within the next couple of days, the density of the infiltrate had reduced significantly out here on the 7th day, on the 10th day, and by the end of 2 weeks, the infiltrate has scarred completely, the vision had improved, the inflammation had reduced, and we had a very, very satisfactory outcome. So now let us go to the second patient, and this is a very interesting patient. in treating microbial keratitis, we often make inadvertent mistakes. And these mistakes are not intentional, but the learning from these prevents us from repeating the same mistakes again. So this was a 42-year-old farmer who did not give us a history of any trauma. There was no known risk factors, and he came with a 3-day duration, symptoms of 3-day duration in his left eye of pain, redness, and watering. And if you look at the clinical in the slit lamp photographs, you can see that there is a very thin epithelial lesion that was staining with fluorescein. It was a linear, a dendritic kind of a lesion. The visual acuity was fairly good. So we diagnosed this patient as HSV epithelial keratitis or dendritic keratitis, and we treated the patient with acyclovir ointment 5 times with homeotropin. The patient came back in a week's time, and this time we found that there was stromal edema with Descemet fold, which can be seen in these 2 photographs. So we presume that the patient had progressed from a central edema, from an epithelial keratitis to an endothelitis. So let us take again your opinion now to see what would you have done. So what would you do next? Would you add topical steroids to treat the endothelitis? Would you continue the patient on the same medication? Would you add a topical antibiotic, or would you reassess the case again and think that maybe it's a different kind of an infection? So 49% of you all think that we should add a topical steroids, but 33% also are concerned that we may be reassessing. We should reassess this patient for a different etiology, and maybe it's something else. So what did we do? We added topical steroids, but probably we should have, thinking that the epithelial lesion had progressed to an endothelitis. So we added prednisolone acetate 8 times, also started the patient on oral acyclovir twice daily. This is the prophylactic dose to prevent epithelial recurrence of herpetic keratitis. Boom, patient came back a week later with a ring ulcer. In retrospect, we should have probably listened to the 33% of you who said we should have probably reassessed it. And what we actually have now is a ring ulcer. And when we did a corneal scraping, we found that there were double-walled cysts. I'm sure you can see that in the corneal scraping. I'm not able to get my pointer there. So I don't know if you are able to see my pointer, but these are the double-walled cysts that you can see. So actually, this was acanthamoeba keratitis, which we misdiagnosed as herpes simplex keratitis. And because we added topical steroids, there was an extreme flare-up. So we treated the patient with chlorhexidine eye drop, which is a bimidine, and half-hourly and atropine, and also added oral anti-inflammatory drugs. And it took us 2 months before we could heal the patient. So acanthamoeba keratitis can have what we have termed and others have termed as acanthamoeba epitheliopathy. That is, in the early stages, these lesions can be, the infection is only restricted to the epithelial layer, and that can become a diagnostic challenge. And one needs to be very, very suspicious about atypical lesions. One also needs to be suspicious about dendrite, whether actually it's a true dendrite or a pseudodendrite. In our case, it was a pseudodendrite, and that's what landed us with soup because of this case. But because the patient was in follow-up and we had access to chlorhexidine, we got a good result. So acanthamoeba keratitis, there are multiple drugs. I'm not sure if everybody out here has access to this thing, biguanides or the diamidines or voriconazole or miltefosine. But the main agents are PHMB, polyhexamethylene biguanide, or chlorhexidine, and recently This again, a landmark paper for acanthamoeba keratitis was the ODAC trial, where Dr. Dart from Moorfields Eye Hospital did show us that using PHMB uh, in a landmark, in a randomized control trial using PHMB 0.08% uh, alone had very, very good uh, results, good outcome. So we didn't have any RCTs for acanthamoeba keratitis before. Other agents are the diamidins, propamidin, but if you don't have access to it, chlorhexidine and polyhexamine is fine enough. If you don't have access to any of these three, then you can try with voriconazole and oral miltefosine. We don't have access to oral miltefosine, so my experience in the other drugs are very, very less. But we have been using chlorhexidine for a long time, and you can get very good outcome with either chlorhexidine or PHMB. So let us come to the third infection. And although it is titled emerging infections, this is actually a misnomer because all microorganisms have been here from time immemorial. It is only now and with advancement in our understanding technology that we start diagnosing these new infections. So this was a 23-year-old farmer who came to us with a symptom history of 12 days. There was a history of trauma with paddy leaf while he was in his doing his farming activities. There was no known systemic risk factor. And on presentation, he was using both antibiotic and antifungal agents. So we had a large central ulcer, the surface of which was dry. The margins were fuzzy. There were some small pinpoint satellite lesions away from the main body. And the infiltrate was whitish gray. And there was some amount of clearing at the center. So we did a corneal scraping. And both the potassium hydroxide mount and the gram stain showed us aseptate and sparsely septate hyaline fungal filaments. So you can see the fungal filaments out here. And there are very few septa. There's one septa somewhere out here. And they are broad and there are some foldings out here. So we treated the patient with, we made a diagnosis of fungal keratitis and we treated the patient with natamycin, half-hourly atropine. We added oral ketoconazole because the ulcer size was very large. And during follow-up, on the very next day, instead of getting a fungal colony on blood agar, we got a very peculiar colony. And this colony, if you can see on the left-hand side on the blood agar, is a flat, blackish to brown, translucent kind of a colony. And when we took a lactophenol cotton blue mount from that, and we stained the fungi that we saw, they were not actually fungi. So you can see out here that these are very broad kind of filaments which have got this 90-degree bent. And what we were actually dealing was not fungi, this was Pythium insidiosum. So Pythium keratitis has been reported from the 80s. The first few reports were mainly from Thailand, but it did not catch most of our attention till the last one decade when in India at least we started noticing and diagnosing many cases of Pythium keratitis. The problem with Pythium are several. One is it resembles fungal keratitis, and that's why the misdiagnosis with fungal keratitis is very, very common clinically. Even experienced microbiologists can have difficulty in distinguishing between the Pythium filaments from fungal filaments. Pythium is not actually a fungi, it's a parafungi, it's a oomycete. And the second problem that we face with it is that, because we think it to be a fungi, Pythium are not susceptible to antifungals. The Pythium cell wall doesn't contain ergosterol, and ergosterol is the main target for most of the antifungal agents. So treating Pythium with antifungal agents are actually doesn't give you good outcome. And there was initially when we did not know much about Pythium, how to treat Pythium, we used to get a lot of perforations and we used to lose eye, and we had to resort to early therapeutic penetrating keratoplasty. But then again, a very important paper was published from L.V. Prasad Eye Institute, Hyderabad in India, where Bagga and his team, they advocated the use of antibiotics, and they advocated the use of linezolid and azithromycin, and they found that uh, by using these antibiotics, they could reduce the rate of therapeutic penetrating neuroplasty by more than 2/3. So for this patient also, we used linezolid in a concentration of 0.2% eye drops. Linezolid is not available as an eye drop, so we reconstituted from the intravenous preparation. Fortunately, linezolid IV solution come as 0.2%, so we just need to transfer it and use it as an eye drop, azithromycin eye drop 1%, and oral azithromycin 500 milligram twice daily. And with this treatment, yes, as you can see, over the period of next 4 to 5 months, the ulcer slowly started responding. And at 1 month, there was central thinning, and so we had to use cyanoacrylate adhesive and bandage contact lens to prevent it from perforating. But the ulcer responded, and you can see that we had a very good outcome at 5 months. So that was about Pythium, and we still find Pythium to be a challenging infection to treat. So my fourth patient is where we couldn't identify the causative organism initially. So it's a case of culture negative, and you can see it was a very long and challenging experience for us with this patient. So this was a very elderly gentleman, 82-year-old gentleman, who came to our clinic with a symptom history of 1.5 months. There was no history of trauma or any other systemic risk factor. Interestingly, we had treated him for corneal ulcer in the other eye. This was the right eye. In left eye, 9 years before this presentation, he had come to us, and we had treated that patient for a corneal ulcer in culture negative corneal ulcer. There also, we did not get an organism, but the ulcer had healed. And this time he had presented out here, and you can see that the ulcer, this had a grayish kind of a yellowish white infiltrate. There were two main bodies of infiltrate, and in between there was some bridging infiltrate. There was no epithelial defect, and the infiltrates were either deep stromal, or in some places it was mid-stromal to deep stromal. And there was small amount of hypopyon. So we did a corneal scrape. Everything came out to be negative. So we treated the patient with moxifloxacin and atropine, and we waited for the culture report. After a week, the culture was negative. There was no change in the infiltrate density or the hypopyon. But what we noticed was, if you can see the arrow out here, there was an immune ring. And given that this patient had had an ulcer previously, and now that patient was having another ulcer, elderly patient, known ocular or systemic risk factor, we thought it could be herpes, stromal keratitis, and necrotizing keratitis. So we added oral acyclovir and prednisolone acetate eye drop, because that's the treatment for herpes simplex stromal necrotizing keratitis. And over the next few weeks, we saw that the patient responded to the treatment. By second week, the hypopyon had reduced, the cornea had cleared up, the density of the infiltrates were reducing, and by 6th week, he had almost got a cure, but there were some small areas that were still had this infiltrates persisting. And 15th week, we thought we had a cure, but there were some areas in the ulcer we thought that the infiltrate was still persisting. We continued the patient on oral acyclovir antibiotic and tapering topical steroid in tapering dose. And then in 24th week, he seemed to have a flare-up. And at this stage, we again re-scraped, thinking that we might be dealing with a fungi, but we did not get an organism. We did not have access to PCR, that is polymerase chain reaction test, or we did not have access to a confocal microscope So what we did was we just wanted to confirm that if we are actually treating patient correctly with or as herpetic keratitis, we did a serology and the IgG was positive. So we continued with oral acyclovir and topical steroids. Again, after 25th, 20, 32nd week, he had resolved. But again, on 44th week, there was again some flare up. You can see on the top infiltrated had flared up. And subsequent to that, there were 4 more relapses. And this kept on happening, this waxing and waning course of the ulcer. At 60 weeks, we found that the ulcer had become now quite severe, and in the lower part, it had broken through the epithelium, and there was some area of thinning also. So we scraped this bottom part, and we did a scrape, and in the scrape, in Gram stain and in Giemsa stain, we found that these small gram-positive spherical bodies, and these are microsporidia spores. So what we are actually dealing was not herpes stromal keratitis, but microsporidia keratitis. Now, the problem with microsporidia keratitis is that it only responds to a drug known as fumagillin. Fumagillin is not available in India. We didn't have access to fumagillin. So we advised a therapeutic corneal graft. And you can see that the outcome was very, very good with this corneal graft. You can see how the cornea had cleared by 4 weeks, and we could maintain this graft like this for many, many months. And when we did the histopathology from the half corneal button, we found, you can see again, this microsporidia spores inside the stroma in the acid-fast stain and also in the hematoxylin eosin stain. And it confirmed our diagnosis of microsporidia keratitis. So microsporidia are unicellular organisms, and there are many, many species out there. And this delay in diagnosis, the failure to diagnose the disease, and this 44-month chase that we had with this patient, it is not unusual with microsporidia. Results from large institutes from India have said shown very similar experiences. Most of the patients that they had got was referral patients, and in those referred patients, it was either referred as HSV stromal keratitis, which we initially thought, or fungal keratitis. And even in their institute, if the initial diagnosis had been made as a herpes simplex virus stromal keratitis, then the mean duration to actual correct diagnosis was 94 days, and median was 17 days. So microsporidia keratitis can have a clinical picture that mimics herpes stromal keratitis, and if in the initial scrapes microsporidia is not identified, it can lead to a delay in diagnosis, as in our patient. So let us come to a quiz again. So what is the approach in cases where corneal scrapings and culture are negative, but the infection is still progressing? So would you re-scrape the patient after stopping all the antimicrobial agents, corneal biopsy, confocal microscopy, or all of the above? Yeah. So 69% of you all have reported that we can resort to all of the above. 3% have voted for confocal, 15% for corneal biopsy, and 13% for a rescrape. So these are all the measures that you can do when you don't have a positive scrape. You need to give an antimicrobial agent holiday to stop the drugs for 24 hours, continue the patient on atropine, and again do the rescrape. If you have access to PCR, then you can send the scrapes for a PCR. A corneal biopsy can be done. If you have access to confocal microscopy, you can do the confocal microscope you can pick up acanthamoeba, fungi, and pythium. You cannot pick up bacteria. So these are all the measures or steps that you can do if you have an initial scrape that is negative, but the infection continues to progress. So let us go to our final patient. And I borrowed this title from a very old Hollywood comedy movie. But in the clinic, when you have polymicrobial infections, it is, believe me, not a comic situation. So this 32-year-old female patient had come to us with a 1-month history of pain, redness, watering, and reduced vision. There was an incidence of trauma with a paddy leaf. She was married to a farmer, so helped her husband in the fields. She was again using multiple antibiotic and antifungal eye drops. On examination, we found that there was a very large corneal ulcer, whitish gray in appearance, and there was a peripheral groove superiorly. And this appeared to be like pythium. And we couldn't see much of the anterior segment details because of this large ulcer, but the B-scan ultrasonography showed that the infection was restricted only to the anterior segment. So we did a corneal scrape, and in KOH and in gram stain, you can see that these are aseptate fungi. The microbiologists also reported that there were some septase also. And you can see this typical folded appearance, a ribbon-like folded appearance. There's a fold out here. There's a kind of a terminal bend. And on the first day, on the first day only, we got the typical pythium colonies. So we made a diagnosis of Pythium keratitis and started the patient on antibiotics, linezolid, azithromycin, and oral azithromycin. The ulcer responded. However, the groove that we had seen initially, that deepened. So we applied cyanoacrylate adhesive and we waited for the ulcer to resolve. It was not worsening. So we are very, very positive that you would get a cure with topical drugs, a medical cure. But even after 3 months of treatment, the ulcer size and density had not reduced. So we thought of changing linezolid to, azithromycin to tigecycline. So we added tigecycline, but even after 2 weeks of treatment of tigecycline, the only thing we got was a yellowish discoloration, but the ulcer continued to remain like that. So we had reached an impasse. So we thought that instead of prolonging this inflammatory episode, we should go ahead with a therapeutic corneal graft. So this is a short video of a therapeutic penetrating keratoplasty that I would like to share. So we measured the diameter of the ulcer, and you can take a 0.5 or 1 millimeter larger size. So we took a trephine of 10 millimeter. I didn't want to go right up to the limbus. So we did a partial trephination. You need to be careful that you don't exert too much of pressure. And we could achieve a good trephination. You can see that it was 90% depth. Then we entered the anterior chamber with a number 11 blade and then used our right and left corneal scissors to excise the infected portion. There was a very thick and AC exudate membrane, which we carefully separated it from the iris and lens surface, taking care not to damage the lens. In therapeutic keratoplasty, the lens acts as a barrier from spread of the infection to the posterior segment. We also did 2 PIs, trimmed the descemetes, 2 PIs to prevent pupillary block, and then we used a fairly fair quality tissue and we applied 24 sutures. So these are the first 2 cardinal sutures that we are taking. So the surgery was very uneventful. We could maintain the anterior chamber, and we are fairly happy with the outcome of the surgery. And this was 24 sutures. You can see that the cornea is also fairly good. The anterior chamber is formed. And next day, you can see that the first day, it was very, very nice. So we continued the patient with linezolid, azithromycin, and atropine eye drop. But A week later, the patient came back with 2 sites of infection. This was recurrence in the graft. You recognize a corneal in a graft recurrence because it usually arises from the uh, graft host junction where those 2 arrows are. Meanwhile, interestingly, the corneal button, instead of fungi, instead of pythium, it grew aspergillus colonies. You can see this dark aspergillus colonies of the half corneal button that we have sent to microbiology for culture on a blood agar. The exudates, pieces of exudates had also grown fungal culture. And this you can see the lactophenol cotton blue mount staining, and which shows us that these are typical Aspergillus niger spores. We had also sent a half corneal button for histopathology, and there was some confusion between pythium and fungi, but you can see these broad filaments, and it favored pythium. So, because we got a culture of Aspergillus, we stopped the antibiotics. We knew that this recurrence was because of fungi now. So we started the patient on natamycin eye drop, voriconazole eye drop, and oral voriconazole. And in 4 to 5 weeks' time, the recurrence resolved. The graft failed. I'm sorry, I don't have the last follow-up visit. The patient had come last week, but we missed taking the photograph. But this is a corneal diagram, and when you don't have access to a photo slit lamp, corneal diagrams can give you, you can use corneal diagrams for documenting your ulcer progression, and it can give you equal information, or in fact more information than what a photograph can give you. So we were able to control the infection in this. So I would like to conclude now, and at conclusion, I would like to give you 5 clinical pearls, 5 insights that we gained from each of the 5 patients that we saw. So the first patient taught us about how we can use topical steroids in bacterial keratitis. And if used judiciously and appropriately, it can lead to very good outcomes. From patient 2, we learned that all dendrites are not because of HSV. In early stages, acantholytic keratitis can only present as an epithelopathy, and one needs to distinguish between a true and a pseudodendrite. A true dendrite would take double stain. The base would take stain with fluorescein, and if you have access to rose Bengal, the margins would take a rose Bengal stain. It would have a branching pattern. The tips of the branches would be bulbous kind, so that would give us a kind of an so that's what a true dendrite looks like. A pseudodendrite can be like this, a very thin linear lesion like this. Sometimes a healing abrasion can also give an appearance of a pseudodendrite. You can have some very short dendrites in herpes zoster. So one should be able to distinguish a pseudodendrite from a true dendrite. From patient 3, we learned about a new emerging infection, pythium, which is now increasingly being reported from India, and an organism that looks like fungus, talks like fungus, eats like fungus, but is not fungus, and you cannot treat the patient like fungi. You need to use an antibiotic. From patient 4, we learned that Microsporidia stromal keratitis, which is different from microsporidial keratoconjunctivitis, can have a very long waxing and waning clinical course if we suspect it to be either fungi or we suspect it to be herpes stromal keratitis. So in this kind of cases where you have improvement with topical steroids, but the infection comes back once you taper the steroids or stop the steroids, one needs to rethink and need to rule out microsporidial keratitis. And lastly, we need to know that sometimes there can be more than one infection in the ulcer. More than one pathogen may be there. It can be a fungi and a bacteria. If you had seen, our microbiologists had reported seeing both septate and aseptate fungal filaments, but because the aseptate made us jump into the Pythium uh, Pythium wagon, and because we got the culture of Pythium, it led us astray for some period of time. And so one needs to always be concerned about polymicrobial keratitis. So I hope that the time that you have spent here in this webinar today from all over the world has been rewarding to you, and that our experiences in managing microbial keratitis that we have shown to you out here has offered you some insights that you can carry forward and practice in your own clinics. So I think I'll stop sharing my screen here and see if there are any questions in the chat box. So the first question is from Dr. Molly Banerjee. How can we identify pseudodendritic keratitis? I think I have this thing what I call answered that in my talk already in the just a few minutes back. The second question is from Dr. Shabana. How do we prepare chlorhexidine? Preparing chlorhexidine can be tricky. You need to actually the concentration is 0.02%. You need to have access to the chlorhexidine, and it depends on what percentage of chlorhexidine that you get. If you are getting chlorhexidine as 20%, then you'll need to titrate that 20% down to 0.02%. I'd be happy to share the dilution if you send me an email, which was there in my first slide. Then from Dr. Fadi Zekert, what are the types of culture and tinction we should do initially to corneal keratitis to increase the possibility of positive diagnosis? What is the type of culture? And I'm not sure I'm able to understand what you meant by tinction. So for corneal culture, so if you're thinking about the treating, how do you do a corneal scrape? I think I have a short video. Normally we do a corneal scrape at the slit lamp, but if it's a small child or there's a perforation, you can do it in the operation theater under a general anesthesia. A corneal scrape, you use 4% proparacaine. You use now it depends upon what kind of a laboratory access you have. If you have an in-house laboratory or if you have media with you, then you can take 3 slides or basically 2 slides, minimum of 2 slides, one 10% potassium hydroxide and the other for gram stain. And if you have access to media, then you can plate it directly on the blood agar, on chocolate agar, on a seborrheic dextrose agar, and a liquid media. We choose blood agar because blood agar can grow both fungi, and it can grow fungi, it can grow bacteria, it can also grow Pythium. Seborrheic dextrose agar can only grow fungi, and we use a liquid medium sometimes because most of the patients come already using antibiotics. So by using a liquid medium, we dilute the concentration of antibiotic in the scrape, and so we can get a better yield. So if you do not have access to media, then if the laboratory is far off, you can use a transport media to transport the scrapes from your clinic to the laboratory. But because the corneal scrape, the amount of corneal scrape that you get is very, very minimal, it is always a very good practice to have directly plate the media, plate the scrape on the media. Also, if you do not have access to media at all, if you have access to a light microscope, at least you can do a 10% potassium hydroxide stain or a gram stain. There have been studies from rural centers in India where potassium hydroxide can give you. You just need to distinguish if it's fungi or if it is bacteria. And potassium hydroxide stain can give you a sensitivity rate of as high as 90 to 95%. If you distinguish between fungi and bacteria, then half your job is done. Why did you use azithromycin in the treatment of fungal infection? It was a polymicrobial infection, and so that was a polymicrobial infection. Initially, we thought it to be pythium, so we treated the patient with azithromycin. Later, we made course correction when in the corneal half button we got fungus. If there's an epithelial defect, do we still use corticosteroids? That's an interesting question from Dr. Christina. It depends why you have that epithelial defect. If that epithelial defect is because of trauma, then you need to wait. But if that epithelial defect is part of, say, a patient of rheumatoid arthritis who has landed up with a corneal melt, or has peripheral ulcerative keratitis secondary to rheumatoid arthritis, a Murren's ulcer secondary to Wegener's, then even if you have an epithelial defect, you need to use topical steroids. And even if you can use topical steroids in bacterial keratitis also, most of the bacteria, leaving aside nocardia, and you can get actually very good results from that. So, okay, how do you differentiate microsporidial stromal keratitis from microsporidia keratoconjunctivitis? That is also a very good question. And the questioner has not named himself. So microsporidial keratoconjunctivitis is, the infection is restricted only to the epithelium. And you get white coarse SPKs. If someone has thrown powder on the cornea, and if you stain microsporidia keratoconjunctivitis, they will stain very brightly, and these SPKs, the punctate lesions, they appear to be stuck onto the epithelium. While as microsporidial stromal keratitis acts like a bacterial ulcer. So if you remember the fourth patient, the infection appeared to be like a bacterial or like a herpes stromal kind of a keratitis, a yellowish infiltrate. And you can only diagnose it if you are able to if you're able to identify the spores in gram stain or in potassium hydroxide wet mount. So these are the same organism causing two different infection. Keratoconjunctivitis is often self-limiting. It doesn't need much of treatment. You can either debride the SPKs or treat the patient with any antibiotic. Because they're only restricted to the epithelium, the infection resolves once the epithelial cycle is completed. So the basal cells would get shed off, and along with it, the microsporidia also gets shed off. Or you can hasten the infection by using a number 15 blade to gently scrape off the epithelium, and that also and give a topical antibiotic, and that also resolves. Then another person has asked, I noticed that most of your patients seem to have been managed as outpatients. Would you admit a corneal ulcer patient? In my setting, we admit most patients. That's also a very, very nice question. So it depends on your setting. Yes, we manage most of our patients as outpatients, but we do admit some patients, especially if the ulcer is very large, patient is from very far, if there is perforation, or if there's going to be an impending perforation, you can admit the patient. You can admit the patient and follow the patient very daily. So that is also perfectly fine. If you have a small ulcer and patient can come for follow-up, that can also be treated as an outpatient. So from Dr. Alvaro Tovar, what is the proportion of positive cultures do you have in any way of improving the positive culture rate? So in our laboratory, the culture rate is around 60 to 70% positivity. So how do you improve the positivity rate of your cultures? One, you can have multiple medias like blood agar, chocolate agar, sebrose dextrose agar, potato dextrose agar, and a liquid medium like a brain heart infusion or a thioglycolate broth. Then direct plating is very important. So you need to plate the media directly. Instead of sending it to a transport media, you need to use a number 15 blade. Sometimes, like because we are a tertiary care setting, so many of our patients come to us with multiple, using multiple antimicrobial agents. So you can give a drug holiday. You can ask the patient to stop using all antimicrobial agents for a period of 12 to 24 hours. Continue the patient on atropine sulfate, topical atropine sulfate, and uh, anti-inflammatory drug, and then scrape. If you do not get anything on the scrape, you give broad spectrum antibiotics. Continue the antibiotics for 48 to 72 hours. See how the infection is progressing. If there is a response, continue with it. If there is no response, you can think of a second scrape. As you have discussed already, you can go in for a corneal biopsy, a PCR test, or a confocal microscopy if you have. So from Dr. Eric Mando, the question is what to do in a setting with no laboratory settings. And even in the pre-webinar, webinar poll registration, there were a lot of questions which had asked, what do we do to treat microbial keratitis or corneal ulcers if you do not have a laboratory setting? And this is not peculiar to any particular country, but it's even in India also. In India, most of the ophthalmologists, they do not have access to a laboratory where they can do a corneal scrape. So does it mean that you don't treat these ulcers? Or does it mean that only places with a microbiology lab should treat all the ulcers? The answer is somewhere in between. So there is something which is known as empirical treatment of corneal ulcers. Now, empirical treatment of corneal ulcers means you look at the ulcer and you do not use, and you treat it thinking that it to be a particular organism, and you do not do a corneal scrape and you treat. So this is particularly advantageous in areas where there is resource limitation. The problem is, like in India, if you look at the causes of corneal ulcer, in India and in most of Southeast Asia, you have a large percentage, you have equal percentage of proportions of patients with bacterial keratitis and with fungal keratitis. And if you look at studies from all across the globe, many of the countries face a similar situation like us. So an ulcer has a 50% chance, or maybe 45% chance of being bacterial, 45% chance of being fungal, and rest of the organism comes within the last 10%. But suppose you are in a very temperate climate like Scandinavian countries, United States, northern United States, where bacterial keratitis predominates, then the chance that the likelihood that the ulcer that is coming to you is bacterial is very high. And in that case, you can just use an antibiotic. But in other situations where it is proportions can be equal, then it becomes more challenging. So what is the middle way? Corneal specialists would say you should do a corneal scrape, and people who do not have access to this, but then we can't do a corneal scrape. The middle way is that if you get a patient and that is appearing to be and you know what is the predominant organism causing corneal ulcers in your setting, if it is bacteria, then it is well and good. You start the patient on a broad spectrum antibiotic. And if the patient doesn't respond in the next 48 to 72 hours, then you refer the patient where there is facility for corneal scrape. You refer the patient at the first visit to a center with corneal scrapings if the patient is one-eyed, if the ulcer is more than 4 to 6 millimeter, if there is central corneal thinning, if there's hypopyon or AC exudates, or if the ulcer has perforated. In these settings, you need to refer the patient immediately. And if you are in a setting where there is both fungi and bacteria, then you should, in my opinion, and there can be contrary opinions to this, you should treat only with a topical antibiotic and reassess the patient 24 to 48 hours later. If you see that there is a response, only stick to topical antibiotic. Do not give an antifungal also, or for good measure an antiviral. And these patients should resolve if you are given a broad spectrum. By broad spectrum, I would like to emphasize a fourth generation fluoroquinolone, either gatifloxacin 0.5% or moxifloxacin 0.5%. Even for gram negative, you should start off with ciprofloxacin 0.3% because ciprofloxacin has the lowest MIC for Pseudomonas and gram negatives. But it would also depend upon the antibacterial susceptibility reports from your area. So you should try to see the literature, see if there is any report in that. In the pre-poll, in the pre-webinar, someone had said that they get very good results. In Yemen, they get very good results with gentamicin. Fortified gentamicin, 1.4%, 14% solution of gentamicin was a part of the fortified antibiotic regimen. Unfortunately, in India, we are finding a lot of resistance to aminoglycosides. So after using this for moxifloxacin or gatifloxacin for 48 to 72 hours, if you are seeing that there is no response, or if the ulcer is appearing to have hyphate edges, endothelial exudates, dry looking, then you should probably refer it to a patient center where they can confirm that it's a fungi, or nowadays we need to also distinguish it from pythium and then treat these patients with that. Why shouldn't we give multiple drugs? We shouldn't give multiple drugs because it can lead to drug toxicity, and sometimes ulcers that do not respond, if you stop all the antimicrobial agents and just give a atropine and a lubricant, it resolves. So we should understand that about antimicrobial toxicity, which is not part of this talk here, but that is also a concern. And antifungals, the response to antifungals are slow, so you might need to give this for 2 to 3 weeks. And suppose it's not fungi but bacteria, it's going to worsen. And in contrast to bacterial ulcers, fungal ulcers response is slow. So it is better not to start antifungal straight away. And for heaven's sake, please do not also add an antiviral thinking that this is, it can also be a virus. So giving multiple antibiotics is not a good way to treat a corneal ulcer. How long should we put the patients on steroids, and how shall we taper it? As soon as you get the response, you can start tapering it and under the cover of antibiotics, and then stop it as soon as you get a complete healing of the infiltrate. The infiltrate becomes scarred, and one should be able to distinguish active stromal infiltrate from a scar. And for there was a question in the pre-webinar, this thing that how long should we continue with the antimicrobial agents? So you can continue with the antibiotics 5 to 7 days after you have clinically declared it to be healed, and antifungal for a week to 10 days after you declare clinically that the ulcer has healed. For acanthamoeba, because acanthamoeba can persist as cyst in the stroma, you may sometimes need to continue with the chlorhexidine or PHMB for 2 to 3 months. Is there a role of vitamin C in healing corneal ulcers? Currently, there is no role of vitamin C or even oral antibiotics in bacterial ulcers. The only indication for oral antibiotics that I feel is if there is a corneal perforation, then you may think about giving an oral antibiotic, so that because oral antibiotic can have very good concentration in the anterior chamber or in the vitreous, especially moxifloxacin, then that is the only indication. Otherwise, for corneal ulcers, oral antibiotic, oral vitamin C, they do not have any role. Neither does povidone iodine drops. Someone as Dr. Eric has also talked about povidone iodine. Povidone iodine also doesn't have much role in treating keratitis. There have been some studies. The reports have not been very, very encouraging. What is your first line medication for microsporidial infection? First line for microsporidial infection, if you have access to fumagillin, I've never seen the drug, I've never used it. It's not available in India. So we don't have a first line medication as such for microsporidial stromal keratitis. For microsporidial stromal keratitis, therapeutic corneal graft. You can give people have tried topical and oral voriconazole. I have not, so my limitation in that, I would prefer to give a go in for therapeutic graft. For microsporidial keratoconjunctivitis, any antibiotic would do. You're just waiting for the either for the epithelial defect that you have caused from your corneal scrape to heal, or you're just waiting for the epithelial cycle to be complete. So the superficial layers get shed off, the microsporidial get, you can just treat the patient with a lubricant. I have already Dr. Saugat Samant has asked for pseudodendrite and true dendrite. I have already answered that. For dry eye patient, diabetic patient, for dry eye patient, they can perforate very fast. So you need to be very careful, be very, have a lower threshold for using cyanoacrylate adhesives. For diabetic patients, their blood sugars need to be controlled, especially if it is the fungi. So fungi do not respond very well to in diabetic patients. Should fluorescent staining always be performed? The name is not there. So fluorescent staining, if you use fluorescent staining, you should only use it after you have actually studied the infiltrate characteristic very well. If you or your assistant has stained the ulcer before seeing the infiltrate very well, some of the characteristic feature of the infiltrate can be masked. Fluorescent, why do we need to do a fluorescent staining? To outline the margin of the epithelial defect. And to outline the margin of the epithelial defect, you can do so if you do a very careful slit lamp examination, and if you make a very, very thin, slit, you can and follow it from intact or normal cornea. You can see that at one point there is a change in the anterior margin of that slit, and it becomes irregular. And that junction between the smooth and irregular anterior margin of the slit section is your margin of your epithelial defect. One is, how do you deal with perforated fungal keratitis or ulcer? Okay, so if it is either bacterial or fungal or any corneal ulcer which appears to be perforating, number one, how do you know it is perforating? By again doing a slit lamp examination. So if you do not have a slit lamp, you probably should not be treating corneal ulcers. Slit lamp examination of corneal ulcer is very, very important. So when you examine the patient with a slit lamp, if in the previous visit there was nice dense yellow infiltrate, and suddenly in one part of the ulcer you are finding that the infiltrate density is less, make a thin beam and try to gauge the distance between the anterior part of the slit beam and the posterior margin of the slit beam, and that will give you the corneal thickness. Desmetocele appear as clear droplets in the infiltrate. So if you are getting this kind of a desmetocele or a pre-desmetocele, or if the slit beam and you measure and you compare the thickness of the slit beam on that particular affected area with the periphery or with the normal cornea, and you make a subjective percentage of thinning. If the thinning is around 90% or more, then these patients have a very high risk of perforating. The best and most useful medium to take care of this case is using a cyanoacrylate adhesive. I have videos of cyanoacrylate adhesive, but there's no scope of showing it out here. So if you have access to cyanoacrylate adhesive, you can put a cyanoacrylate adhesive and a bandage contact lens. If the perforation is very large, so cyanoacrylate adhesive and bandage contact lens is good enough for ulcers of 2 millimeters. If it is larger than 2 millimeter, or if the iris has already presented in the perforating site, you can still glue the iris and can form the anterior chamber if possible with air. But if you cannot maintain the anterior chamber and if the perforation is very large, then you need to send the patient for a therapeutic corneal graft. And if the ulcer has perforated, then you can give oral antibiotics in a bacterial keratitis to prevent the infection from going into the vitreous. And in fungal keratitis, you can give oral antifungal drugs. Then if you have a persistent dendritic ulcer from Dr. Hajar, Ismail Mohammed Hajar, if you have a persistent dendritic ulcer, which was a geographical ulcer, which has improved markedly, but there is no complete healing, the top of the ulcer still, patient is on systemic and topical acyclovir and weak steroid. I am following him now for almost 2 months. Your advice? So, a dendritic. So, if you have a herpes simplex epithelial disease that is not improving, then it can be because of multiple reasons. The most common would be drug toxicity. Usually, herpetic or geographical ulcers in primary, in say the first episode, they heal within 7 to 14 days. If they are not healing, then probably you should look at your regimen of your antibiotic, antimicrobial agents that you're using. If you're using an antibiotic as well, what kind of antiviral you are using, that is one. Second, the patient can have a neurological component which is there. And if you are using a weak steroid can also retard healing. So I understand that there would also be in your patient some amount of stromal component, which because of this duration that is there. So I would advise first you reduce the number, you look at your prescription and stop all topical drugs that are not necessary. You don't need to treat an epithelial keratitis with both oral acyclovir and topical acyclovir. Topical acyclovir is good enough, but in this case, because if you're suspecting a drug toxicity, you can switch to an oral acyclovir. So if even after stopping all these topical drugs that are not required anymore, there is no response, then you can think about a tarsorrhaphy. A tarsorrhaphy will usually heal the ulcer. If a tarsorrhaphy is also not this thing, and it can happen, then you need to look if you're missing out on some other factors. If there is some kind of an infiltrate, do a scrape and see if there is a secondary infection there. If despite all those things, it has still not healed, you can consider an amniotic membrane if you have access to that. So these are the ways that you can go about treating a non-healing ulcer. So you need to think about the neurological component, a suture tarsorrhaphy, that is you just close the eyelids by passing a Prolene suture or a 4060 Prolene or a 4060 silk and tie a knot in a paramedian area for a week to 10 days. You'll find that there is a healing. You can release the suture after that. So you don't have to do a permanent tarsorrhaphy. I think it's nearly 7:45. And I think Lawrence, I think we can actually stop it right now. And I think there are no more fresh questions that are there. How often should we monitor IOP? So you can monitor IOP by doing a digital tonometry, or if you have access to Tono pen, that's a this thing, a proprietary product. You can use that, and you should judge it each visit so that you rule out secondary glaucoma. So thank you all those who have asked questions and all those who have answered, who have participated in this program. I hope I was able to convey some of the challenges, some of the insights of microbial keratitis that we have been dealing. All these patients have contributed to my understanding and my learning of corneal ulcers, and each patient that we treat of corneal ulcers gives us a nugget of information. And I've been able to collect, hopefully, this nugget of infection for last 2 decades that I've been treating corneal ulcers. And hopefully, I've been able to share some insights which you would find useful in your practice, in your day-to-day practice and your clinic. Thank you very much for attending this webinar and, for attending this so actively with all your questions. Thank you very much. I hope I've done justice to your time. Thank you.